Hello and welcome to EMS Research with Professor Bram, where we talk about the research-related issues that matter to those who work in emergency medical services. Today, we'll be talking about research related to obesity, race, and income. So stay tuned for the interview. I'd like to welcome you to the EMS Research vlog and podcast from the studio here in Houston, Texas. I'm your host, Bram Duffy. I'm a full-time paramedic on the streets, just like many of you. I also have an appointment as a research fellow with the Institute for Social Innovation at Fielding Graduate University. I actually have a research study open now for first responders. So if you don't mind being interviewed by me, then go to my website at professorbram.com. It's professorbram.com, and click on Current Research tab to apply. Find out more information there. But before we get started, I want to share that I've written 2 books on communication, and the most recent book that was just released is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. I'll be telling you more about it near the end of our time together today, but if you want to check it out, you can see the link below to find out more. Today with us, we have Jamie Kennel, who is an accomplished individual, has a passion for academia and healthcare. I'd like to tell you about him. He has a master's degree in human factors from Embry-Riddle Aeronautical University and a PhD in medical sociology from Portland State University. And Dr. Kennel has an appointment as a professor at the Oregon Institute of Technology. He's also an experienced paramedic. His dual role as a healthcare professional and also an educator allows him to bridge the gap between theory and practice. This offers valuable insights into the field of medical sociology and its application to real-life situations. So that's why we have him here today, and I'm glad that we can take advantage of his experience. So welcome to the show today.
Thank you. It's great to be here. Thanks for having me.
Yeah, so in the Annuals of Emergency Medicine issue from 2023, you were the second author of a study that looked at ambulance patients with long bone fractures. And it really drew some headlines. It was called Racial, Ethnic, and Socioeconomic Disparities in Out-of-Hospital Pain Management for Patients with Long Bone Fractures. And the results showed that Black patients were substantially less likely to receive out-of-hospital pain medicine when they compared to white non-Hispanic patients. The difference was not explained, when we looked at clinical presentation, patient preferences, or the socioeconomic conditions. So can you tell us more about this study?
Yeah, you bet. So as you mentioned, Dr. Crow and I did this work, and it has a number of important distinctions in it, and it's a continuation of research that has been done in this field really for decades in other areas of medicine, but only about in the last 5 or 8 years it's been done in EMS. So this particular study, as you described, what we did that was unique in it and what's important in it is that we took confirmed long bone fractures from hospital data, and then we looked backwards into their EMS care. Because we wanted to identify pretty objectively painful injuries. And so we can get around a little bit to the subjectivity of our pain score that we use, because there's been critiques in the use of it in the past. Somebody's definition of severe pain is different than others. So we have confirmed long bone fractures, looked back in the EMS record and asked a few questions, some really simple ones. Who received pain management and who didn't? And this is just the dichotomous measure of pain management. This is not which type of pain med or the dose variation of pain med, but just who received it and who didn't. And we found consistent racial disparities, as you mentioned, that African Americans were much less likely to receive pain medication treatment despite the same injury, and controlling for differences in severity of pain score, as well as gender and age and insurance status. Some other really interesting and concerning findings were found in 2 other areas in this study in particular. One of the critiques in disparities research is that racial minorities might be offered pain meds but refuse more often through a long-standing, well-justified distrust of the healthcare institutions. So what we wanted to do is look to see if there was evidence of a difference in the rate of refusals of pain meds. This is a difficult thing to research because it's often not objectively captured in the chart. Mm-hmm. So we hand read about 2,000 narratives of folks that were not given pain meds. And we had a committee of folks review them. I was one of the committee members, and we didn't know what the race of the patient when we reviewed them. And we were looking for signs that the paramedic had charted. I offered pain meds and refused. After we categorized all of the narratives, 2,000 of them or so, then we did some simple statistics to see was there a difference in refusal rates. And we found no evidence there was a difference in refusal rate. And in fact, there is some preliminary evidence that suggests that white patients were more likely to refuse pain meds than Black patients in this particular sample. The third really interesting thing about this study was there hasn't been a lot of research done in EMS about socioeconomic differences in treatment. And so this particular study, we used census data, the Social Vulnerability Index, which is an established index that factors in about a dozen different criteria to understand the socioeconomic status of a census tract. And so we simply looked at, you can hover up and think about this, do people in poor areas of the city receive the same treatment as people in rich areas of the city? For the same injury. And not unexpectedly, we found that if you lived in a poor community, you were less likely to receive pain meds than if you lived in a wealthy community.
I have lots of ideas about what's going on here, but you're the expert that's spent all the time with this. What's some of your best guess?
Yeah, it's a good question. And I want to draw some distinctions here, right, which is important in research. This particular study, as many of my past studies so far, have been understanding if there is a disparity. The brain wants to go into why does this disparity exist, which is important, and some important next steps so that we can get to interventions. So importantly, this study doesn't understand why, it understands if or does this happen. So when I review the literature, as recently wrote up in the EMS1 article about this particular publication, I think there's a handful of mechanisms that might be at play that affect both racial disparities and class disparities in treatment. One is language proficiency. Excuse me. And in the scholarship, individuals that don't speak English well are called limited English proficiency patients, or patients with LEP. These are difficult patients to treat. They're difficult patients to treat in the hospital. They're difficult patients to treat in EMS. If you cannot communicate with somebody verbally, that is a very difficult patient to treat. Many EMS systems have interpreters, many do not. And so often EMS providers are left to do the best they can using informal tools that are not official medical interpreters, like Google Translate, like I know a little bit of Surfer Spanish, I'm going to use that, or some really primitive hand signals. And some providers just say, I'm going to drive to the hospital and not give you any treatment because I know they have an interpreter at the hospital. So this is important because most LEP patients are both poor and are racial minorities disproportionately. So when LEP populations suffer a reduced or a substandard of treatment, that dramatically impacts the racial disparity and the class disparity in their care. So that's number one. Number two, regarding race, is there's still a fallacy that there's evidence suggesting that people believe, especially medical providers, believe that race is a biological construct instead of a social one. There's a great study at UVA, which we can talk about, but a large number of medical students still believe that African Americans in particular are physiologically different, things that have been proven false for years and decades, but medical students still believe that they're true. Things like their blood coagulates faster, they have fewer pain receptors, their skin is thicker, etc. So that's number two. Number three is aversive racism. This is in racial scholarship. We're in the third phase of racism in society. First being chattel racism or ownership of people. Second being state-sponsored racism or Jim Crow era. And third is aversive racism, which is really a discomfort, but an explicitly feeling of wanting to be equal and fair, but when you're in the back of an ambulance with an individual who is different than you, you may feel a little bit uncomfortable. This is where the idea of implicit bias comes in. That's number three. And number four, and this is a long answer, I apologize. Number four is relative to social psychology theory around cognitive load, in that when individuals or healthcare providers in particular are under heavy cognitive load, so you've got a really complicated patient, there's a lot going on, you're under time pressure, you have a lot of clinical ambiguity, meaning you don't really know what's going on internally. Is it a break? Is it not a break? I can't do a scan. I can't do lab tests, etc. You have to make some decisions in an imperfect, stressful situation. In those particular instances, we have to use heuristics and stereotypes, and those heuristics and stereotypes come packaged with good things as well as baggage and negative bias.
Mm-hmm.
And so anytime we are in situations that rely on stereotypes, there's a greater chance of bias creeping in. So I think those four mechanisms are largely at play as we think about this. And I think one important distinction to make here also, Bram, is that a knee-jerk reaction is quickly to say that we have broken providers that are providing disparate care. That is not largely the case here. There's humans involved, I believe. There's humans involved, and so there will be bias involved. Racism, like classism, is a structural concept. And so agencies, through various means of motivation and signaling and intrinsic rewards, are allowing and in many times encouraging this kind of behavior. And if they aren't actively doing quality CQI efforts that look at the quality of their care, they are a player in condoning this kind of behavior to their communities.
Yeah, and I want to mention that the four mechanisms that you just talked about were the ones that you wrote about in that article that came out in 2019 that was shared in EMS1.com. I think that you do a really good job of being able to look at this from different perspectives. And as a provider, I have to be honest and say that I am walking into a new situation, and the first concern I have is myself, right? Safety. And so when we think about things safety related, one of the things that we do cognitively is we use the stereotypes that we have based on the past experiences that we've developed to help protect ourselves. So I know that we're running into an adrenaline-filled moment, even though we try to reduce the adrenaline that we have, but it puts us in a position where we maybe do have some more reliances on that. So one of the things, if I'm just shooting from the hip, that just sort of bothers me is I'm thinking, well, maybe someone might look at a patient and think, well, because you're African American, maybe there's a higher chance that you are a drug seeker or something like that, because of the stereotypes that person has. And if something like that goes into the thinking consideration, then it's unethical and it's concerning. But we have to, I think, be able to break down and understand where all these ideas are coming from, just so that we can make sure that we're treating people accurately. And so when you write about this stuff, I think it expresses and sheds light on, gosh, what's really out there that are going through these moments. Because I can tell you that the majority of EMS professionals are going to look at you and say, I'm not racist. And I have studied this issue quite a bit from different angles, and I would say that it's really difficult to say that with a good deal of accuracy. Now, I don't mean, what I mean is that there's a difference between having stereotypes and then using those stereotypes for negative reasons. And I think that that's what racism is using those stereotypes for negative reasons or things that could prevent you from being able to understand the situation as accurate as you could. I'm going to bug you about something that you did recently, because it's just like 10 days ago you put this article out, our EMS treatment disparities related to race or class is what it's called. And the subtitle is Ensuring Equitable Treatment for All Communities Begins with Understanding How Unintentional Racism Can Produce Racist Outcomes in EMS. One of the thoughts that I had especially when I got into like the second paragraph and began reflecting on this information and the way that you share it, one of the things that you wrote, and I'll just read it: EMS clinicians are explicitly non-racist. We need to have uncomfortable conversations and comprehend the structural root causes influencing desperate treatment administered to patients of color. You know, when I was in graduate school, we talked about race a long time ago with understanding race in education and disparities from what we called whiteness studies. That was what the overarching topic was referred to. And nowadays it's called critical race theory. CRT is what's in the news media, and it's made into a very political, messy issue. But I just want to point out that if providers, if everybody had an understanding of the other person in a deep way, then it might do a long shot to solve the problem. And so what I'm saying is that, gosh, this critical race theory stuff that we're all of a sudden not supposed to be teaching in schools, maybe that's one of the magic bullets to help this, because it gives, just understanding the structural inequalities and how someone is different and how the situation is what it is a much different perspective than me versus them. And seeing the other person as just someone that's different, it comes with some understanding. And so what this whiteness studies and this critical race theory does is it just sets us up to be able to stand back and evaluate, and not evaluate, but just have a deeper understanding of why is someone different than me and what got them to this level, not just them, but whole groups of people. I know you don't talk about that directly, but I just wanted to see your thoughts. What do you think about that?
There's a lot to unpack there, and I think you're absolutely right. The concerning direction that places like Texas and Florida are heading, that are arguing that slavery was a good thing for African Americans, is just astounding. And the push to avoid understanding the truth of our history, I think you're absolutely right, is going to do a disservice and will further divide our communities, right? I think the example that you provide is great in that, and I teach this to my students a lot, and as well as at EMS conferences. One of the things we have to do is look inward into ourselves. And if within our social circle, as an example, if it's a homogenous social circle, so if all my friends look like are white and cisgendered and of the same wealth status, if they're all the same, where am I likely getting my understanding of what African Americans, as one example, are like? I'm probably getting it from the media predominantly. And there's study after study that demonstrates the media's representation of African Americans, as one example, is impressively skewed, in that African American males, to your example, are violent and prone to outbursts and are constantly drug seeking, right? One of the best TV shows made, The Wire. If I get my understanding of African American community from The Wire, and I'm a paramedic, just as you described, and I go on scene, and my first thought should always be about my safety. If I'm informed by the media about what people who are different from me are like, I'm going to walk into that situation feeling unsafe, even though it's not a realistic depiction of African American community. It's a media depiction of it, right? So in a way, that is certainly unintended from the paramedic in this case. However, the paramedic in this case, just like you and I, have a active responsibility to have a diverse social circle so that we can fight this desire to make these overarching stereotypes, whether it's about Asians or Hispanics or women or people who are obese or people that don't speak English, right? If we are informed by outside groups and not by our own personal experience, we're going to have a very skewed and warped view of what those communities are like.
Even if we have lots of exposure to different people, we are still continuing to develop our stereotype. We're sort of watering down the pool a little bit if we're, if I'm going to have at least 5 Asian friends and at least 10 Black friends. I'm joking to show that these relationships that you have with each other really do help with those connections. And I think that it helps you understand the person better. I know this is not related, but I think it's an interesting thing I want to mention because I think it's kind of funny too. But the television show that was called Modern Family, remember that
Yep.
sitcom? So my view, because I'm older, so my view of media and the United States and acceptance and understanding of one another, I kind of feel like that television show helped gay people immensely because it helped the American public be able to see that gay people can have a family just like straight people, and they can belong to a bigger network of other family, maybe non-traditional. And so I just want to say that I felt that change. And I think that show and other things too in our media have helped. And so I also want to mention that when I was a kid, I grew up in Southern Illinois, and everyone was white for 3 counties. I would have to drive 3 counties away to find someone of color. And so myself as a child learned about people who are different from me based on television, Sesame Street and everything else that I saw. And so those views of other folks, it's accumulative, so it's media based also. I want to pick apart something that happened in your article that was just released because it really was crazy to me. You mentioned that there was another research study done by the ESO Data Collaborative that looked at it's one of the largest EMS databases out there. Mm-hmm. And this was showing that 72% of white patients with severe pain got drugs and 59% of Black patients did not. So it's like a 13% difference. That's just pretty huge because of the numbers of people we're looking at. This was over 35,000 reports, that were analyzed to see this. And so what this tells me, this information, and coupled with the studies that you've done, really show that people that have that are in lower socioeconomic status and folks that are of color, they're just not going to get the same treatment. And so it's at least possible. When I looked at the remarks, that people can say things about your article, and I think the EMS one, sponsors that, and they want people to have a healthy dialogue. Mm-hmm. But one of the things that the first commenters, and the poster doesn't really have a name; it's just a bunch of letters and numbers. The statement that they make that I highlighted in their paragraph was that they were saying that the bias of the authors taints the believability for what they have to say. Some horrible comment like figures don't lie, but liars can figure. And then he goes on, or she goes on to talk about an unrelated STEMI example. But the thing is that I think that some of the folks that make comments may just be in a position where they don't understand research. And so, someone like you or myself who specializes in research we know that the information that comes from the research work that we do has validity. And even if it's quantitative, a number is a number, that there's provable data. And so when someone says they don't believe your research, or maybe they are someone who doesn't understand what you've gone through to figure this out, and maybe they just read the byline of the, or of the title. This is why I think it's so dangerous how we see EMS as a profession in the United States, because we only, it seems like, are looking at training EMS providers to be allied health professionals. And it's true that we're not just technicians anymore. We do so much more than that. And the disadvantage that I talk about all the time is that if you're in Australia or in the UK and you get a bachelor's degree in EMS, and your last year is going to be focused on EMS research, your senior year is that. And our folks here in the US don't get that. And so there comes with a lot of just not understanding even what research is. And then when I, as a research professional, look at that, it makes me think about, gosh, well, I mean, is this just someone that's racist that's saying no? Because what you're putting out is fact, and so you can't just say I don't believe it. It's just not possible to do that. Instead of saying I don't believe it, you need to come in and say, well, I've done this other investigation, and this other investigation says this. And that's how we learn and grow and figure things out. So it's just sad to see some of the comments. Another one says, this is just another example of the pervasive woke ideology that's spreading over every institution in America to say that Black patients didn't receive the same pre-hospital anesthesia as Caucasians. And your article fails to elaborate on any rationale. That's not true, and it accuses you of race baiting. This is just, another example of how it seems like someone is taking their own views or their own opinions or experience and just dumping it on a research study. And I think it's dangerous because their lack of understanding is perpetuated by, not having an understanding. When I write stuff and I get comments back, I respond to them, and I know that I shouldn't, but I feel like that there has to be some kind of check and balance. The very last person says, I don't agree with this article. Are some providers racist? Probably, but to say a person has been misdiagnosed, mistreated is pushing race a bit too far. Well, it's not pushing it too far. It's pushing it exactly far enough. It's pushing it to what the number says, and then that article showed from ESO was 13% difference in Black versus white getting pain medicine. I was really happy to learn about your research, and I want to just, recognize the fact that there is some pushback. And I think that the pushback is really related to the fact that not everybody knows what research is all about. And I want to thank you so much for doing what you do, and accepting the criticism that come from people that don't understand what you do.
Well, thank you. I appreciate it. And I think you're right. And having been in this space for a number of years, in publishing works as well as at EMS conferences speaking on this, as well as learning from other race scholars, everybody is on their own journey in this topic. Certainly not having an appreciation or an understanding of what it takes to do kind of rigorous research puts them at a disadvantage. But I also think one of the big disadvantages people have that don't have a research background is the weight of personal experience and the weight of somebody's ego, my own as well, in saying, this is not the type of provider I want to be, and I don't believe I'm this type of provider, just permeates and kind of overrides any evidence-based inquiry about something that's different than what I feel like my personal situation is. So of course, providers don't believe that they treat people differently. And then when they're confronted with evidence that suggests it, many of them that don't give it a second to reflect, give it some critical thinking, might just come out with comments like what you've described. And so, there's various strategies I've attempted over the years to handle this. And I think importantly, the work required to help people move along their journey should not be placed on the individuals who are oppressed, right? So, for example, asking African Americans to do this work to help other white folks understand this challenge and the complexity and how to solve it. To me, my view is white people created this problem. We should have a huge role, not an exclusive role, but a huge role in helping to solve this. So it should be my labor that helps individuals along. Now, I choose to often help people that are a little further along in their understanding on this journey and have gotten over the phases of denial and anger and are now ready to have some self-reflection to say, boy, I don't want to be like this, but I've not looked at my own data to know if I am like this. And so help me understand, but using my own data, how I can get better, not as a punishment, not as a shaming or a blaming, but this is not the provider I want to be. So help me get stronger.
Yeah. And
those are the folks I usually focus on, because the other folks can be really frustrating to interact with. And so I applaud you for engaging in anonymous comments online, especially.
well, and I think that we also should close with the fact that we are both white men, and
Yep.
we're talking about an issue that, like you said, that was caused by our side of the deal. And it's easy to maybe think about our conversation as disrespectful because we're not including a person of color. But the reality is that there are other people out there, there are other scholars out there that are addressing this issue that are of color. But your way of doing it it's just really special, because I think that you're able to take information and show that things just are a certain way and not deniable. And that's pretty cool, because not always research doesn't always work out that way. So
Absolutely.
Well,
Absolutely.
I think
Go
that
ahead.
ends our time, and I have information on the down below if folks want to contact with you. And I just want to say thank you again for being here.
You're welcome. Thank you for having me, Bram. I appreciate it.
Right on. Take care. I want to invite you to check out my latest book that I co-authored with 4 Arrows, and it's called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. And the book works to change the way we communicate with patients who are dealing with the emergency situation. And the book really works to help us think about how, instead of interrogating our patients, we have an opportunity to take advantage of the hypnotic trance that they are already dealing with because of the fear and the intensity of the moment. So looking at how we can take advantage of that hypnosis component is really exciting. And so I'd like to invite you to check out our book. And if you like an autograph, it's real easy to send me a message, and I'll be able to send you over an autograph sticker that can just go in the inside book cover. But I also look forward to your feedback about what's going on in hypnosis and emergency medicine. I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Just go to my website at www.professorbram.com. It's Professor B-R-A-M. And you'll be able to learn more about the research study and fill out an application form. Thanks again for listening to this episode. And if you've enjoyed EMS research, please tell your friends and like, share, and subscribe so that we can continue to spread the message. Thank you again.